Okay, thank you very much. So this was, this session is controversies, and just in talking with some of the delegates, still this thrombophilia is a controversy, and there's a lot of studies that we want to review. So first we're going to talk about normal hemostasis, what's normally happening in the body. What are some of the different inherited thrombophilias? What are some acquired risk factors? And then understand some of the potential risks of the thrombophilias to women who are pregnant. So the normal hemostasis is a complicated system that involves many coagulation factors that eventually result in a fibrin clot. And they're known. There's 20 different control steps in this process, and there are probably many that we still don't know. For example, factor V Leiden, when I went through medical school, nobody knew factor V Leiden. It was discovered in 1993, first reported. So many of the doctors my age and maybe a little bit younger never heard the word until after they got out of practice. There are natural antithrombotic mechanisms that we all have to prevent clotting. The first is the endothelium. This blocks the lining of the blood vessels, blocks platelet activation and fibrin accumulation. Antithrombin is the last step in the coagulation pathway. It's the last blocking point to prevent blood clot formation. And so antithrombin, protein C, and protein S are all natural anticoagulants. So if you have deficiencies in any of these factors, if you're low in antithrombin 3, low in protein C, or low in protein S, you have a relative hypercoagulation state. I get a call once a week from somebody, "Oh, Billy, I have a patient whose protein C activity is high, and the lab has flagged it, dark letters. What do we do? Do I put them on Lovenox?" I said, no. The low one is the one that you worry about. Now, who knows which one of these three goes down in every pregnant woman? Is it antithrombin? Is it protein C? Or is it protein S? Who wants to vote antithrombin? Goes down in pregnancy? Nobody. Protein C? Protein S? Okay, here we've got one person. So if you draw protein S activity in any woman who is close to pregnancy, who is currently pregnant, it's going to be low every time. It naturally goes down. So if you're looking at these tests, you have to know what happens in pregnancy and not just start throwing Lovenox at all these patients. So without worrying too much about this, these are some of the factors. You've heard of some, factor 5, factor 8, factor 10, and again here is the fibrin clot. If we have a hypercoagulable state, what does it mean? Hyper, increased coagulation, clotting. So these can include primary, which are inherited genetic factors, and acquired, such as antiphospholipid antibodies, obesity, these type of things. Any of these factors can increase the risk of a patient to get a blood clot. And these factors are additive. The more that you have, the greater that the risk is going to be. Pregnancy itself is a hypercoagulable state. When I was in medical school, I definitely did not want to go into hematology and study this because they didn't know anything. They didn't know pathways. Nobody understood how it worked. It was very frustrating to go into this field. After I finished and got interested in this field of pregnancy loss, I had to buy the books and start reading about hypercoagulation and these pathways. And the thing that's amazing, it seems when you start studying the changes in pregnancy of the coagulation system, it's a miracle every woman who becomes pregnant doesn't have a blood clot. You start reading, this factor goes up, this factor goes up. You would think, and the protein S goes down, you would think everybody has a blood clot, but it's not the case. So there's more things going on completely than we understand. But some of the changes, We already said protein S goes down. Activated protein C resistance, which is a marker for factor V activity, increases. And then the liver is activated by estrogen, which is up during pregnancy, and a lot of the coagulation factors are increased. This is all pregnant women, not just miscarriages or some other condition. But still, most of them don't have a thrombotic event. They don't have a blood clot. Let's just look at two factors. One is factor V Leiden. This is the most common inherited thrombophilia. It's a mutation in the factor V Leiden gene. When does this factor V Leiden get diagnosed by any doctor? And this is why OBGYNs need to know the information. The majority of patients with factor V Leiden are diagnosed when they're either pregnant or on birth control pills. Why? Because pregnancy increases the coagulation risk, and birth control pills increase the coagulation risk. So OBGYNs are going to make more of these diagnoses than the general hematology oncology doctor. They're going to be referred to the hematologist. And antithrombin deficiency, it's the same way. Most of these patients who are diagnosed in women are either on pills or pregnant when the diagnosis is made. So it's important for OBGYNs to understand these, what we should and shouldn't be doing. So we talk about the inborn thrombophilias, protein S deficiency, protein C deficiency, antithrombin deficiency. Remember, if these are low, your risk for thrombosis increases. And then mutations in factor V Leiden and prothrombin. Really, all these are mutations. There are hundreds of deficiency, protein S deficiency mutations that we know can cause it. The same for protein C. So really, they're all genetic. If you just look in the general population at the frequency of venous thrombosis and which are the associated factors, this is just not pregnant women, this is all patients. Factor V Leiden mutation will be found in a quarter to a half of the patients. Antiphospholipid antibodies, 10 to 20%. Now, I put a little asterisk by antiphospholipid antibodies. This is the only one that's associated with both arterial and venous thrombosis. The others are venous thrombosis. And then you can see the frequency of the others declines. So we'll focus first on factor V Leiden, which is one of the most common inherited coagulopathies. It's present in about 5% of the population, but it varies depending on ethnic background. In Asians, it's maybe 2%. In Spanish, it may be 9 or 10%. So there's difference. I talked to some people at the conference. They say in the Middle East, it's maybe 5 or 6%. It is a single mutation in factor V. Now, why is this single mutation so important? Factor V is a clotting factor that activates the coagulation pathway. And all these factors are activated and inactivated. If you cut yourself and you're bleeding, you need something to get activated to stop the bleeding, but you also need a way for it to stop. The coagulation factor gets inactivated very quickly, and if the bleeding has stopped, there's no more activation of the clotting factor. The mutation in factor V Leiden is exactly at the point where factor V gets inactivated. So it cannot be inactivated, and it keeps going continually. And this is why it puts people at risk. If you have a heterozygous, one copy, and this is again general, and in this room there are probably 10 or 15 people that have this factor V Leiden mutation. Does anybody know that they have it? One. All right, there's probably 14 or 15 more people in this room right now who have this mutation. Anybody, you don't have to raise your hand, but probably none of you are on Lovenox or heparin.
There's probably 14 or 15 more people in this room right now who have this.
Protein C deficiency. It's also a factor. Protein C is one of the factors that's important to cut factor V. And we're going to see how these are related. So remember, factor V has to be inactivated. Protein C is one of the factors that inactivates factor V, and if protein C is low, you have a relative increase activity of factor V. So if you have a deficiency in protein C, you have relatively more active factor V Leiden. The frequency is not very common, 1 in 250, but we measure activity, 1 in 500. And I've shown over here on the chart protein C, and we're going to find out in a minute protein S is important. Protein C has to be activated in order to cleave and inactivate factor V. So, the ways to diagnose protein C deficiency, we recommend testing for activity. You can have low antigen level, the protein is not being made, and therefore the activity is low. But you can also have normal protein production, but there's a mutation and it doesn't form. So if you measure activity, you're going to pick up both of these. So we say test for active protein C or functional protein C. Protein S deficiency, it's the same. If it's low, you increase your coagulation state. So a high protein S, we don't worry about it. It's found in a free form and a bound form. The free form doesn't work. It has to bind, and it binds to, guess what? It binds to protein C. So protein S in the free form has to bind to protein C to activate protein C. And when protein C is activated, it cuts factor V. It inactivates factor V. So now we see protein C, protein S, and factor V Leiden mutation all are very closely related. They all increase the activity of factor V, either directly or indirectly. How do we test for protein S? You can get very complicated, and none of us are hematologists, so the easy thing, you test for protein S activity. If you test for the antigen or the free form, you might miss some of the rare diagnoses, or just send the patient. ACOG now says, don't mess with this if you're OBGYN. Send the patient to the hematologist. The problem we have is the hematologist is going to put everybody on Lovenox. We know the solution before they go there, or heparin or something. But we test for the activity. Is it too complicated, this picture? Let's see. All right. Here's protein C, if I can make it, down here. It has to bind to protein S. And when protein S binds to protein C, you have what's called activated protein C. When protein C is activated, it inactivates factor V. It also inactivates factor VIII, I didn't mention, but it inactivates coagulation factors that need to be inactivated. This is the normal situation. So if you have low protein C, low protein S, or factor V Leiden mutation, you are in a hypercoagulable state. Antithrombin deficiency. Many effects of antithrombin in the pathway. This is not only the most important factor, it's the last stopping point in the coagulation pathway, and deficiencies in antithrombin are the most clinically critical situations. Why? Because antithrombin does not work through the heparin pathway. If you have somebody with antithrombin deficiency, you can hook up the IV to Lovenox. This isn't going to help. You have to give these patients antithrombin. So this deficiency is the most clinically significant one, fortunately uncommon. Now, if it wasn't for the doctors, antithrombin deficiency would be gone. What would happen? These women that had antithrombin deficiency would get pregnant, they would get on birth control pills, they would have a fatal thromboembolic event, and the antithrombin gene won't be passed to anybody. That'll be the end of it. But this isn't what we do. We treat them, we let them have babies, and they pass this gene on to their children. So if it wasn't for the doctors, this thing would go away. The people would have a blood clot and be gone. They wouldn't reproduce. But antithrombin deficiency you also can test by just activity.
This is what we do. We treat them, we let them have babies.
So what about early pregnancy loss? We did one of the first studies in 1999. This was becoming very popular. People were testing. We had just 50 women, and we evaluated prothrombin gene, factor V Leiden, and MTHFR, methylene tetrahydrofolate reductase. As a comparison, we listed antiphospholipid antibodies. This is one of the acquired ones. But we reported absolutely no difference in the frequency of these factors in women with recurrent pregnancy loss. Now, 18 years later, there are thousands of papers looking at this same thing. People are still arguing, but this small study is what we think is the case. There's not a significant difference. This was one of the meta-analysis from 2003. They looked at the same thing, factor V Leiden and protein C, protein S, early and late pregnancy loss, and they concluded maybe there was some increased frequency of these abnormalities. This raised the attention, and around this time ACOG said we should be getting these panels of thrombophilia on everybody, and we thought everything was caused by thrombophilia, preterm labor, stillbirth, maybe even chorioamnionitis, but everything was going to be thrombophilia related, and all the problems in OBGYN were going to be solved with what? Lovenox. Finished. We don't need any more experts, just put them on Lovenox, and all the problems are going to be solved. So we were doing these things. The problem was the OBGYNs don't know anything about thrombophilia. We didn't go into hematology. We didn't know what's factor V Leiden. And so this went on, this crazy situation went on for years and years. Here was another study about the same time. They looked at the clotting factors, case control, they looked at factor V Leiden, and there was the conclusion. Factor V Leiden and factor II gene mutation have double the risk of 2 or more miscarriages. Now, the problem with these studies, here's another one, British Journal, it shows the same thing, systematic, 79 studies. My God, this is a huge study. And lots of patients. All women had at least one thrombophilia. And my goodness, look at this. You would think women would be falling over every day in the labor hall from thrombophilia. But it's not happening. What's the problem with all these studies? All of these, big meta-analysis. If you know these authors, these guys are not OBGYN. Who are they? They're hematologists. Who do we send to the hematology? Who? Somebody who had a blood clot. So the entry group for these studies was the patient had a thrombophilia. We send the patient to the hematologist, and then they write the paper. Of course they're going to have more thrombophilias. We've already weeded out the patients that had a thrombophilia and sent it to the hematologist. So here were the OBGYNs. We were seeing all these papers published by hematology. They have a very select group of patients, just like if you ask me, how many patients have recurrent miscarriage? I'm going to say, my gosh, 30 to 50%. This is what I see in clinic, because they all get funneled. The hematologists were getting funneled, all the patients with thrombophilia. And so the papers they publish are biased, very biased. But we lived with this literature for years and years, and we did so many things and treated so many patients probably that didn't need it. 30 to 50%. This is what I see in clinic. We looked for years and years. We studied all our patients, factor V Leiden, factor II, protein C, protein S. We had controls. We stopped after about 1,000 patients because we couldn't see any difference. These are not patients coming to the hematologist. These are patients coming to a fertility clinic. They don't have blood clots. They're healthy young women. We didn't find any increased frequency in any of the patients. The same results we found from 50 patients 10 years before. And now more meta-analysis are coming. And the The risk factors, you remember, they were 2 and 3 and 4. The risk factors are showing low, but still some studies are showing the risk is very low, less than 1%. And what does ACOG say now? ACOG says, who should we test? 2 groups of women. Not everybody who comes in, not everybody who fails IVF, not everybody who has 1 miscarriage. Who do they say we test? Women who had a blood clot, this one, that makes sense, and women who have a strong family history of somebody with a blood clot. And everybody else, what do they say do? Send them to the hematology if you're worried. Why? In the U.S., OBGYNs were getting sued right and left. They didn't know. They'd go on the stand, what's factor V Leiden, doctor? They didn't know what factor V Leiden was. And they were testing and treating and doing all these things. It was a huge problem. But the situation is calming down in the U.S. It sounds like still here in the Middle East, it's going full force. There is insufficient evidence, according to ACOG, to test for the thrombophilias in women who have recurrent loss, and MTHFR, 25 or 30% of the people have it, so definitely don't test. So, they have made a risk analysis table. Factor V Leiden with and without a history of thrombosis, and they make a judgment. If the risk goes up so high, yes, this is a woman who needs thromboprophylaxis. But for the normal patient, they have decided that the risk without a history of prior thrombosis is low, and these women don't need any thromboprophylaxis. These are the guidelines. Recommendations of putting women in groups, very high risk, low risk. What's low risk? Antiphospholipid antibodies. We treat with prophylactic heparin. What's high risk? Antithrombin deficiency, multiple thrombophilias, current venous thromboembolism. Well, definitely we're going to put this person on thromboprophylaxis. And I put a star again with antithrombin deficiency. This one needs antithrombin factor. So, we have to look at lifestyle factors. Somebody with heterozygous factor V Leiden on birth control, her relative risk is 30-fold increase. So we don't put these women on birth control with estrogen. Acquired factors, the main one is antiphospholipid antibodies, which is lupus anticoagulant and anticardiolipin antibodies. Again, the guidelines say don't test for inherited thrombophilias. And long-term treatment for these patients, we say keep them on baby aspirin unless they have contraindication. Avoid estrogen-containing pills. Counsel them about lifestyle changes. What's the lifestyle changes? Lose weight, stop smoking, don't take estrogen-controlling pills. I was involved in one lawsuit. The patient had a factor V Leiden, but he didn't tell her and put her back on birth control pills, and then she had a clot, and they sued the doctor. Did you tell her don't go on birth control pills? No. So if you're going to do these things, you need to take full care. And in the U.S., you're going to be judged against the hematology standard, not against the OBGYN standard. So the final point, this is a balance. You have to look at your patient and say, does she have multiple risk factors that puts her at increased risk for coagulation? Then this may be somebody that needs thromboprophylaxis. And this is not like a light switch. If you have factor V Leiden, you're going to have a blood clot. Factor V Leiden is one risk factor out of many. In the U.S., if everybody with factor V Leiden was being treated with Lovenox or heparin, this will be hundreds of thousands of women every year. Most of them don't even know, just like everybody in this room doesn't know they have it.